Okay, hi everybody. My name is Ibrahim Hussain. I'm an assistant professor of neurosurgery at Weill Cornell, New York Presbyterian, and I'll be giving you a short vignette on the CNS case of the month on minimally invasive spine deformity. These are my disclosures, none of which are relevant. So this is a patient that I saw, a 68-year-old female who presented with progressively worsening back and leg pain. She failed all conservative measures and ultimately was recommended for surgery. On exam, she was neurologically intact and had severe disability from her pain. It's interesting to note that in the right side, she really had an L2-3 distribution radiculopathy, but on the left side was an L5 distribution. These are her standing x-rays, which demonstrated a moderate coronal deformity, but otherwise coronally and sagittally balanced. She did have a PI-LL mismatch of about 17 degrees. On this coronal CT, you can really appreciate the coronal deformity a little bit better, seeing that it's really apexed at the L2-3 level, and there's even a component of lateral aesthesis. I really want to point out the fractional curve at the L5S1 level, which is really compressing the left side, whereas at the majority of her curve on the concavity, it's really from the L2 to L4 levels. On her MRI, again, just redemonstration of the neural compression, really severe exiting nerve root compression from L2 to L4, really moderate at L4. But on the left side, you can appreciate that there's severe foraminal compression of the exiting L5 nerve root. I didn't show it here, but she did not have any significant central canal stenosis. And here's, again, redemonstrating the compression of the L5 exiting nerve root at that fractional curve. Ultimately, the patient failed conservative management, had ongoing disability. So for her, I recommended surgery. I did follow her over time, had built a relationship with her and her family, which I think is important before you consider big deformity correction surgeries, and to really address what the expectations are after surgery. Because she did have adequate sagittal and coronal balance, the main purpose of the deformity operation was really to address the PI-LL mismatch and to see if we could do anything about her foraminal stenosis given the radiculopathy. You can treat these with circumferential minimally invasive techniques, hybrid MIS open, or pure open techniques. Because she was on Eliquis for AFib, I was really more inclined to try a minimally invasive option. And then you have to consider any prior surgeries, any prior fusion masses, if you're going to consider an anterior lateral approach, if they've had any other abdominal or retroperitoneal surgery. And then also just trusting your inner body cages to address indirect decompression when necessary. These are two studies that have come out of the ISSG, the MISDEF2 and the MISA, which I think are excellent sources, which I encourage all surgeons to read about. It provides a rational framework for which patients you can actually treat with minimally invasive techniques based on their radiographic parameters, and also which inner body techniques you should use based on the ultimate goal of surgery. Ultimately, for this patient, I performed an L2 to L5 lateral transpsoas inner body approach from the right side from the concavity, because that allowed me to address 3 levels pretty much through 1 incision. I ultimately did an L5S1 TLIF from the left side to address direct decompression of that exiting L5 nerve root, and then an L2 to S1 percutaneous pedicle screw stabilization with navigation. As I'd mentioned, there are other ways you could do this. For L5S1, you could consider ALIF or an anterior to psoas, pre-psoas approach. In those situations, that would allow you to get a more lordotic cage in, which is purely very beneficial at the L4 to S1 segment. And then with the anterior to psoas approach, which I'm actually not, I've done a couple of them, but I'm not as comfortable with it. You could potentially perform all the inner body work from a single lateral position. So that's certainly a consideration. Ultimately, the approach that I did, the patient was discharged home on post-op day 3, and at 1 year post-op had improved baseline functioning and off all medications. These are just some images from the case. Again, looking closely at the LLIF portion, looking down that camera, you can see the disc space being prepared. And then after the inner body cage has been implanted. These are just some images showing the 3D navigation of our percutaneous pedicle screw stabilization. And these are the post-op films, which showed a significant reduction in the coronal curve from 36 down to 11, and a significant improvement of the PI-LL mismatch to under 10 degrees while maintaining coronal and sagittal balance. Thank you all for your attention during the case. These for this case, there some really nice references I encourage all listeners to check out. And obviously, feel free at any time to reach out to me directly for any questions. Thank you.